Good afternoon. I have no financial relationships to disclose. However, I will be talking about the off-label use of adjustable gastric banding, which is FDA approved only in those people who are 18 years or older. Imagine you're in your clinic and sitting in front of you is this kid. He's 15, has a BMI of 57, which translates into a weight of about 400 pounds. I'm going to use this one instead. Translates to a weight of about 400 pounds. He already has impaired fasting glucose with a prediabetes A1C. He has high triglycerides, obstructive sleep apnea, and pre-hypertension. By a show of hands, how many of you would consider referring him to bariatric surgery at age 15? Okay, one or two. If I told you that his mom had bariatric surgery and that he has ADD and that he's worked in the weight management program for about 3 years but failed treatments with several weight loss medications already, does this change your mind? Now how many would? A few more. So your responses mirror those of a national random survey of pediatricians and family practitioners, which revealed that about 50% of those providers would never consider referring an adolescent for bariatric surgery. And the most commonly reported minimal age at which they would even consider referral is 18. So today I'm going to talk about why would we even consider bariatric surgery in a teenage person. I'll review the most commonly used bariatric procedures in adolescents. We'll talk about how many are happening, where they're being done. We'll talk about outcomes and risks, and then who makes an appropriate surgical candidate. I'll also spend a little bit of time discussing this controversy. Should adolescents even get bariatric surgery in the first place, or should they wait till they're adults? And then finally, we'll talk about adolescent bariatric surgery programs. So first, why even consider adolescent bariatric surgery? Well, I'm talking about a unique population of children. These aren't just children who are merely obese. These are children who have severe obesity. And there have been various definitions for this condition. Some propose a BMI at the 99th percentile or higher, or 1.2 times the 95th percentile, or just a straight cut point of BMI of 35. And there are a lot of these children out there. 4 to 6% of the U.S. Children fall in this category of extreme pediatric obesity. Now, kids who are obese are at increased risk for type 2 diabetes, cardiovascular disease, but this group of kids, those kids on the extreme end, have even higher risk. Already, the vast majority have at least one cardiovascular risk factor, and 5% have impaired glucose tolerance, which is a harbinger to type 2 diabetes. This slide shows the cardiovascular risk factors in a large cross-sectional study of about 10,000 kids. And you can see the nonlinear relationship. Up until 99th percentile, the risks are fairly stable. However, at that 99th percentile, your risk for having these cardiovascular problems increases exponentially, such that about 2/3, nearly 60%, showed it in that dotted line, will have 2 risk factors, and nearly 1/3 will already have 3 cardiovascular risk factors. Non-alcoholic fatty liver disease is also a serious condition that's quite prevalent in children who are in the extreme obese category. One series of 41 adolescents who had undergone surgery and had a mean BMI of 59 showed the majority of them had fatty liver disease, and 1/3 already had fibrosis, scarring on their liver. Aside from the medical comorbidities, these kids have really poor quality of life. This slide demonstrates a quality of life of obese children shown on the far left compared to the healthy on the far right. And you can see obese kids compared to healthy have much lower quality of life, but they also score way lower than kids with other chronic medical conditions, lower than those with CF, lower than those with inflammatory bowel disease, lower than those with type 1 diabetes. When you put kids with extreme obesity on this, they're even lower yet than those in the regular obese group. And the story doesn't end in adolescence. These kids are almost universally grow up to be obese adults, and not just slightly obese adults. This slide shows that kids who are at the 99th percentile at age 12, the majority of them, 88%, will have a BMI of greater than 35 as an adult, which is considered class 2 obesity. So these kids are going to stay markedly obese. And perhaps not surprisingly, their life expectancy is shorter. The average young male with a BMI greater than 45 loses about 13 years of life due to obesity. 20-year-old female with a BMI greater than 45 loses about 8 years of life just due to obesity. So what do we do with these children? Well, like Erin mentioned, the cornerstone of obesity management is lifestyle interventions. That is changing in diet and physical activity by changing behaviors. And this is effective. This is from a review in 2009 that showed that for teenagers, the average change in BMI at 6 months is about 3 units down. And at 12 months, a year's time, you can expect about 3¼ units. Well, if your BMI is 40 or 45, going down 3 units is like a drop in the bucket. Further, there are many studies that suggest that the severity of obesity predicts the outcome, such that kids with severe obesity perhaps respond less favorably to these lifestyle interventions alone. I'll draw your attention to the far right column, the 12 months. You can see those with severe obesity really had no significant change in their BMI Z-score at the end of a year's worth of this lifestyle modification program. This slide demonstrates a similar point, showing kids with less severe forms of obesity on the left panel, more severe forms of obesity on the right panel. Changing by age, we see that those teenagers, older teenagers in the severest forms of obesity don't experience a change in their weight after lifestyle intervention. So then what about medications? What's the role of medications in helping these children? To date, there is only one FDA-approved medication for the indication of weight loss in children and adolescents, and that's orlistat, which is a lipase inhibitor. The largest study by Chanwin et al. Showed only a roughly 1 unit decrease in BMI over the course of a year. There have been many studies that looked at metformin, though it is not FDA approved for the indication of weight loss. It has some weight loss properties, but even that medication over the course of about 6 months showed almost 1 unit decrease in BMI. So not so much. There are other medications that are just recently approved for the use of weight loss in adults. But there's very little safety and efficacy data in children. At least not yet, right, Erin? So you can see these children are large. They have significant comorbidities, many medical, many psychosocial. Lifestyle interventions are helpful to some degree. Medications are fairly limited. For these reasons, people have turned to bariatric surgery to help these children. The first bariatric surgeries were performed in adults in the 1960s, and it wasn't until the 70s and 80s that we started doing them in adolescents. And the first reports were with this jejunal-ileal bypass. This is a severely malabsorptive procedure. Just like it says, most of your jejunum and most of your ileum is completely bypassed. So you have significant macronutrient and micronutrient deficiencies. So bad such that some of these operations had to be reversed. Some adults still get the biliopancreatic diversion, which is, again, another severely malabsorptive procedure. It's reserved primarily for adults with really morbid obesity and not used in adolescents very much at all. The 1970s, 1980s, we saw the emergence of this procedure called a vertical band gastroplasty, and this too was abandoned mainly because of frequent leaks along the surgical line and complications. So today, the most common bariatric procedures that are performed in adolescents are the Roux-en-Y gastric bypass, the adjustable gastric band, and the sleeve gastrectomy. All of these today are most commonly performed laparoscopically. So I'll start with the Roux-en-Y gastric bypass. This is considered the gold standard in both adolescents and adults. It is a restrictive procedure and a malabsorptive procedure. I'll get to that in a second. Basically, what the surgeon does is creates a small pouch out of the stomach. Small meaning holds about 15 to 30 cc's, so they say about the size of one chicken nugget. The jejunum is cut, and a rulum is brought up to that small pouch. And then the biliopancreatic channel is connected back to the distal port of that jejunum. The primary mechanism really is restriction. That is, you can only eat a very small amount, 30 cc's, a half a cup at the most of food. There is a malabsorptive component to it. But most of the jejunum and ileum is preserved, so it's very minimally malabsorptive. The advantages of this procedure is, first, is that it's the gold standard. It's been around the longest. So we have the most experience and history with it, primarily in adults. People who get the Roux-en-Y gastric bypass have very good weight loss, and it's fast weight loss. On average, you can expect about 64% of excess weight loss. So I want to take a minute to describe percent excess weight loss. That's the most common outcome measure that's used among bariatric surgeons to describe the efficacy of a procedure. And it's met with a lot of criticism because it doesn't make real intuitive sense right away. Basically, it's just the percent of the difference between how much you weigh and your ideal body weight. So if you weigh 300 pounds and say your ideal body weight is only 100 pounds, you're carrying 200 pounds of extra weight. If you have a Roux-en-Y, you can expect to lose 60% or so of that 200 pounds of extra body weight, or about 120 pounds. Of the three procedures that are most commonly used in adolescents, this one results in the greatest amount of weight loss. There are no adjustments needed, unlike the band, that we'll talk about later. And there's really good track record in terms of decreasing comorbidities. In adults, 80%, 85% of those with diabetes will have complete resolution of their diabetes. So it is really, really good. For some people, they like to call this a metabolic procedure rather than a weight procedure. The disadvantages are the nutritional risks, and this is the most common long-term complication. It's not reversible. There's cutting of the bowel that's going on. Some people develop dumping syndrome, which is a bad reaction, if you will, to consuming typically high sugar and high fat foods that hit your jejunum really quickly. You get a osmotic diuresis. There's a surge in a big incretin effect, so you're feeling shaky and sweaty and dizzy. It's rather uncomfortable. There are potentially lethal complications. You could die from this procedure. And the question remains, what is the long-term rate of weight regain? The next procedure that I'll review is the adjustable gastric band. And this is purely restrictive. Again, it's not FDA approved in those who are under 18. It involves placing a silicone band at the upper portion of the stomach, about 1 to 2 centimeters below the GE junction. And that band is attached to a tubing and a port, and that port is placed subcutaneously. And by injecting fluid into that port, which is subcutaneous, you can decrease the diameter of the band. If you remove fluid, you open the diameter of the band. So if you're feeling very hungry, you don't, but the surgeon injects fluid and it tightens up the band. So it really limits the volume of food that can be consumed in a single setting. The advantages are pretty good weight loss. Remember, with the Roux-en-Y, you get about 60-65% weight loss. Here's more around 45 to 50% weight loss. If you go back to our 300-pound person with ideal body weight of about 100, 50% would be about 100 pounds off. It's a shorter operation. It takes only about an hour. The morbidity is much lower. It's reversible. If you don't like it, you can have it removed. And there are fewer nutritional deficits than the malabsorptive procedure. The disadvantages are that the reoperation rate can be pretty high. And then the rates vary anywhere from 8% to 20% depending on the series. Our surgeons tell patients that you can expect to have a revision at some point in your life, particularly if you're getting abandoned when you're an adolescent. You need a lot of follow-up visits. On average, in that first year, you need to come back about 10 times for frequent band adjustments. Again, it's not FDA approved. And this procedure, unlike the others, it's user-dependent. It really requires active participation, and this kind of accounts for the wide range of outcomes that we'll see in a minute. The next procedure that I'll talk about is the sleeve gastrectomy. This is the newest one on the block, if you will. This is the first part of a two-stage operation that is currently used in adults, but they found that, hey, after this first stage, after the sleeve gastrectomy, people lost weight. And what is involved is essentially removing the greater curvature of the stomach so that you have a long, narrow, banana-shaped stomach. It's restrictive in that less food can be consumed, but I also put hormonal because grayling is decreased substantially. So the fundus part of the stomach is one of the primary sources of grayling, and grayling is a hormone which increases hunger. So without that grayling, there's less hunger experienced by the patient. Advantages: good weight loss, kind of the middle of the road between the adjustable gastric band and the Roux-en-Y. There's no foreign body, you don't need adjustments, there's no digestive anastomosis, which increases risk for ulcer formation. There's relatively fewer nutrient deficiencies, but it's not zero. Disadvantages: it is irreversible. There's a long surgical line, which increases the risk for leaks along that surgical line, and that can be lethal. And we do have minimal longitudinal data on this. So how many kids are getting bariatric surgery? Where are they being performed? Who's getting them? This table is from Kids Inpatient Database. And if you can see, back in 2000, about 300 procedures were performed. Took a big jump to 2003, where about 1,000 procedures were performed, and that's been stable ever since. Contrary to what I think a lot of people hear in the media, that, oh, the rates of bariatric surgery are increasing remarkably. This also reflects data with adults, that the rates have really sort of plateaued since about 2003. The types of procedures have certainly changed over time as well. You can see back in 2000, the vast majority were open, Roux-en-Y gastric bypasses, and now hardly any are open, mostly laparoscopic. And then we also see the emergence of the adjustable gastric band, now about a third. Where do these kids get their operations? The majority are happening in adult hospitals, in adult institutions. Vast majority. Only a small fraction, 14, 20%, happen in a children's unit in a general hospital, and none are happening in freestanding children's hospitals. I'm not really sure where Amplatz fits in this model. So what are the characteristics of the kids? Mostly, they're older teens. They're 17 or 18 years old. Between 2000 and 2009, there were none in kids younger than 12. So that's good. The majority of them were female. Vast majority were female. If you look at 2000, at the income quartile, back in 2000, the majority come from higher socioeconomic families, whereas now it's a little bit more equally distributed. Going down to insurance, still the majority of patients getting bariatric surgery have private insurance. Now it's interesting, if you take a moment, this pattern does not reflect the general population of obese kids, particularly severely obese kids. Those children generally come from poorer families. They generally do not have private insurance. There's a more equal distribution, obviously, between boys and girls, with actually a slight preponderance of boys in that severely obese population. So really a skewed set of kids that would qualify for bariatric surgery are actually getting it. This data comes from University Health Systems Consortium, which is a database of healthcare outcomes of only academic institutions. And I put this slide up here to show that between 2008 and 2011, the types of procedures has changed quite a bit, with quite a substantial increase in the numbers of sleeve gastrectomies, shown on the left, with a relative decrease in the number of adjustable gastric bands. Overall, though, per year, the total number has remained the same. So, what are the outcomes? How do these kids do? This is a meta-analysis from 2008, so quite a while ago, but it's the most recent one. The top part shows outcomes for the band, and the bottom part shows the outcomes for Roux-en-Y gastric bypass. So looking at the top studies for the adjustable gastric band, years of follow-up, anywhere from 1 to 3 years of follow-up, with inclusion of 58 to 100% of kids. On average, these kids are losing about 10 to 13 units of BMI over that time period. Look at that pooled estimate of heterogeneity, 56%. That means these outcomes are kind of varied. It means that some kids do really well and some kids not so well. For the bottom section that shows the Roux-en-Y outcomes, Follow-up time is anywhere from 1 to 6 years with inclusion of 60 to 90% of patients. These get better outcomes, on average 17 to about 23 units of BMI. That review was from 2008. Since then, there have been several relatively bigger studies of different outcomes for various procedures. And I'm going to walk you through this table one section at a time. In the blue is the Roux-en-Y gastric bypass. There are 3 studies. You see the average number of kids is still kind of low, 11 to 81 kids with a mean BMI at baseline of 45 to 50. You see at 1 year with pretty good follow-up, excess weight loss is about 60%, and change in percent BMI is about a third. And those changes persist at 2 years. And this reflects adult outcomes. For most adults who have a Roux-en-Y, they reach their nadir BMI or weight loss at about 12 to 18 months, and then stay about that weight. For the next section in the yellow, the adjustable gastric band, there are 3 studies, 25 to 73 patients with a baseline BMI in the 40s. But at 12 months and even at 2 years, you can see the numbers that are included in the follow-up analyses are pretty dismal, very, very small. Only 16 of the 73 started for the Nadler, and only 7 of the 23 started for the Lee evaluation. And you can also see that the percent of excess weight loss is kind of all over the place. There's 27% and 56%. So there's a wide range. Then bottom, vertical sleeve gastrectomy. 2 studies, one with 51 kids, one with 99 kids. At about a year, with only half, again, really small numbers, half for the Al-Qatani trial showed excess weight loss 60% to 90%, with about a third of a decrease in your BMI at 1 year, which persisted again at 2 years. So these are small numbers. That's the point here. They're small numbers, and it's only at 2 years. What happens after that? We don't know, really. We really don't know. This was the biggest series of long-term outcomes in adolescents. Only 25 kids. You can see at 9 years, only 4 were included. Pre-op BMI was 45, down by a third to 28, with an excess weight loss of 77%. That's about as good as the data gets. In addition to weight loss, these kids experience significant improvement in their comorbid conditions. Virtually every comorbid condition is improved with bariatric surgery, at least in the short term. And those are listed there. This comes from that meta-analysis of 2008 that showed that diabetes resolution anywhere from 50 to 100%, and the rest are shown. But know that the ends here, the numbers here, are really small. They're all under 15, in all of those cases. So the data is pretty limited. Kids also experience improved mental health. This comes from a series of 16 patients who have undergone Roux-en-Y gastric bypass. They showed marked improvement in depression scores, shown in panel A, improvement in their perceived competence, shown in B and C, and improved in weight-related quality of life, shown in panel D. But notice that the biggest change was between 0 and 12 months. Kind of plateaued between 12 months and 2 years, and almost seems to trend downward afterwards. So it'll be very interesting to see what happens. Do they experience sort of an initial honeymoon phase and then their poor quality of life returns? We don't know. So what about the risks? How safe is bariatric surgery in a teenager? In terms of morbidity, pretty good. These data are from 2002 to 2006, and adolescents have about 5% rate of morbidity 30 days postoperatively. Adults have about twice that. More recently, this shows that the morbidity is really quite insignificant. So 0 morbidity with the surgery and 0 mortality. Now, it doesn't mean that the chance of dying is 0. There have been at least 5 reported deaths in adolescents after bariatric surgery. But the likelihood is significantly low. This is interesting because it compares it to adults. How do kids compare to adults? Even in adults, laparoscopic procedures, not open procedures, but laparoscopic procedures are relatively safe with relatively low morbidity and mortality. So the mortality rate here for these laparoscopic procedures is 0.07. I'm just going to show you for reference. You can look at this middle line at other procedures performed in adults. AAA repair is almost 4, CABG 3.5. So compared to bigger, different operations in adults, a gastric bypass is relatively safe. One of the big concerns for adolescents in particular is the nutritional risk, and certainly vitamin and mineral deficiencies is the most common long-term complication. Kids, because of their decreased total volume consumption and also because of the malabsorption associated with some of these procedures, are at risk for dehydration and protein malnutrition, though the protein malnutrition is quite unusual in the procedures that I described today, the Roux-en-Y, gastric band, and sleeve gastrectomy. Micronutrient deficiencies, however, are very common. The most common is iron deficiency anemia. You need the acid from your stomach to help with absorption of iron, and without some of your stomach, there's less acid and less absorption of iron. It's also harder for some of these kids to consume red meat. Vitamin B12 deficiency has been demonstrated with anemia, glossitis, peripheral neuropathy. Folate deficiency is also quite common and has significant implications for girls of childbearing age. And thiamine deficiency has also been found in a couple of kids with even beriberi and adolescents who have presented to the emergency room with peripheral neuropathy, pain in their extremities, nystagmus, in which case immediate delivery of thiamine is imperative to prevent permanent neurological damage. Vitamin D deficiency and calcium deficiency are also quite common and have significant implications for bone health. So this study comes from a series of 16 kids, and 61 kids who have had a Roux-en-Y gastric bypass. They looked at their bone mineral content. Whole body bone mineral content decreased 5% in that first year, down to 7.4% in the second year. Again, like others, we don't really know how much lower it's going to get. Is this going to persist? Are these patients going to be at increased risk for osteopenia and osteoporosis? It's interesting that the decrease in whole body bone mineral content was only accounted, weight loss only accounted for 14% of that decrease in bone mineral content, suggesting that there are other humoral hormonal factors involved. Probably grayling is one of the big players here because it is involved in somatic growth. Also, it's important to recognize that at baseline, these kids started off with pretty high bone mineral content in the first place, and that by 2 years, although it had decreased, they were still supranormal. So just have to keep that in mind. So who's a good candidate for bariatric surgery? What kind of kids should we be sending? There's no standard, if you will. There's no consensus on BMI cut points. In 2004, the first committee recommendations suggested that children should have a BMI of 40 with a severe comorbid condition or a BMI of 50 with a less severe comorbid condition. And then this idea of what's severe or less severe has also been up for debate a little bit. Severe generally we consider as type 2 diabetes, pseudotumor cerebri. Less severe would be conditions like hypertension, insulin resistance, psychosocial issues. It's recommended that these kids failed 6 months of organized weight management, that they are physiologically mature, that they are emotionally mature, that they can give informed consent, and very, very, very importantly, that they have a supportive family. More recently, these guidelines have been modified because of some data suggesting that this is a relatively safe procedure. The BMI cut points have been decreased to now 35 with a serious comorbid condition or 40 with a more mild comorbid condition. Our group has decided that we would use these as our general guidelines. So, should adolescents even get bariatric surgery? Should we wait till they're adults? I'm not sure what the answer is. Proponents of the earlier is better suggest that, well, the preoperative comorbidities increase the risk of something bad happening during the surgery, and that presumably younger kids are healthier than adults, so it's better to do it earlier. Very interesting research has suggested that the baseline weight is the biggest predictor of weight loss. So to demonstrate, this was a great study by Inge et al. That showed essentially no matter where you start, you're going to lose only about 1/3 of your BMI. So if you're up here at 80 and you lose 1/3, you're still going to be morbidly obese. If your starting BMI is 40 and you lose 1/3, your chances of being closer to normal are a little bit higher. So the suggestion then is that earlier intervention, while the child is relatively smaller, may be better than later intervention. There was also a small study that showed that super obese adolescents described as BMIs greater than 50 had less resolution of their insulin resistance and their dyslipidemia compared to those who are less obese. And we know from adults that the longer you have type 2 diabetes, the more severe your type 2 diabetes is, the less likely that it is going to resolve after bariatric surgery. So again, maybe we should be doing these surgeries earlier before kids have really bad, poorly controlled diabetes. And finally, we know that obesity in young adulthood is associated with poor quality of life. Fewer degrees of advanced education, lower rates of marriage, lower life satisfaction. Certainly, young adulthood is a formative time, and it may have, being morbidly obese may have significant negative impact on that. Well, on the other hand, some people would suggest later is better. And the reasons for this include, do adolescents really have decisional capacity? Do they know what it means to have bariatric surgery and have to eat only a half a cup of food at each meal when they're going to a football game with their friends or going off to college and living in a dorm. What's the long-term rate of weight regain? We don't know exactly. In adults, up to about 20% will regain their weight after bariatric surgery. What's the impact on bone health? We saw from that one study that their bone density decreases over time. What about pregnancy and quality of life? Will there be issues there? Would an adult have better compliance with vitamin mineral supplementation better than an adolescent? It's possible. At least one study shows that adolescents, only 14% of adolescents take their supplements as directed. 14%. So they're not taking it, and they're at very high risk for complications related. Perhaps in the future we're going to have better pharmacological options. Certainly is possible. Or better surgical options. There are, or endoscopic options, if you will. There are all kinds of new procedures, putting in sleeves in your duodenum that can promote weight loss without altering permanently your physiology, or your anatomy, excuse me. So, a little bit about adolescent bariatric surgery programs. Whether you think a patient should have surgery or not, it is important to find a right program for a kid. Adolescents are not small adults. They have very unique needs. It's important to have a multidisciplinary team of specialists that are comfortable with working with adolescents and their families. And not all adult providers are comfortable. A team should have, at the very minimum, a pediatrician, surgeon, dietitian, a mental health provider, physical activity provider, and a coordinator. Ideally, your program would be a center of excellence, a bariatric surgery center of excellence. And this is a distinction given to surgeons and healthcare centers that states that your program is performing a certain number of procedures, that it's safe, there are on-site inspections, and this is because we know that the more procedures you do, the higher the volume is, the lower rates of complications. So if you've noticed in the Discovery Clinic, the bathrooms there, those toilets were retrofitted to have extra supports. That was in anticipation of an on-site inspection to maintain our Center of Excellence designation. So a little bit about our program here. It was formalized, if you will, in November 2011. And I say formalized because it had been going on, but just not in a very cohesive way. Our preoperative program is pretty extensive. It's 6 months long. Each kid has to come for at least 6 visits in that time period. They meet with me, they meet with our psychologist and our dietitian at every visit. There's a whole curriculum that they go through in terms of dietary intervention. There's a whole curriculum that the kids follow in terms of preparing themselves emotionally for this procedure. To date, we've had 19 patients evaluated in 5 operations. 8 dropped out of the program, and it's been for various reasons. Some insurance, but mostly because they just were not compliant with the recommendations. 3 opted out of the program and are still with us, and they have demonstrated successful weight management with medications instead of surgery. And we have 3 that are currently in process. This is our team, our Healthy You Pediatric Weight Management team, many of whom work with bariatric patients. That's Dr. Leslie. He's our surgeon. So after hearing this talk, You go back to your 15-year-old boy. Now, how many of you would consider referring to bariatric surgery? Maybe a few more, but not many more.
He hasn't done the lifestyle.
He has. He has. For 3 years he's been working on it. Yes, the same kid. Sorry, same kid. Okay. That's all I have. I'd be happy to take any questions. Nimmy.
So, Claudia, you and I share a patient who's, I don't know if she's in your study, but she's off in college now, who had her surgery when she was 18, I think.
Mm-hmm. Mm-hmm.
And her story really strikes me because I've known her since she was 13.
Mm-hmm.
And she was an A student, unbelievably motivated, really supportive family, tried everything under the sun, and I really believe that she did the dietary stuff. She really, tried to move her body. She barely budged her BMI. And it made me, in retrospect, think about some of the environmental health and endocrine disruptor kind of issues. And are some of our patients really toxic and, have these endocrine disrupting chemicals that have disrupted their insulin metabolism such that, really concerted efforts at lifestyle are barely going to budge them. And my question to you is, do you hear any new on the horizon kind of efforts to try to understand that phenomenon better or screen for it? Or, where we are, I know this is really early in our understanding of it, but, I look at her and I think of the 5 years of heartache and, all the visits in my office with basically her mom crying and her comforting her mother, her mom saying she's doing everything and nothing's happening. And, I just feel like there's so much more we don't understand.
Oh, for sure. There is a ton there's a ton that we don't understand. So many factors that we can't even begin to even identify. You're right. Many people would consider obesity as a primarily an inflammatory condition. And are there toxins that are causing this inflammation? And is that why we're in part seeing this epidemic? There's never going to be just one reason. It might be a combination of, the toxins, our environment are different, as well as our obesogenic environment, and the epigenetic changes that are coming out. And so it's hard to know exactly what the future is going to hold, but certainly it's super complex, and that does make treatment more challenging because one person may respond to one treatment, but another person may not, and it might be because their underlying etiology of their extra weight is different.
But it was transformative for her. She's just got a different life now.
She did. She had a great outcome. And many kids do, but not all kids. And how do you predict who's going to have that better outcome or not? We don't know. It's a risk you take. Yes?
Just to add to that comment about what else can we do, I'm a pediatric sleep doctor, and we often focus on obstructive sleep apnea as an obvious concern, but it's very important to recognize that sleep deprivation has a significant factor. And we know that kids are sleeping an hour less now than they were 30 years ago. We know that adults are sleeping almost 2 hours less than they were 30 years ago. We know that kids who have texting, computer games, televisions, phones in their bedrooms are 250% more likely to be obese. So we look at things of what else we can do. It's important to understand that the quantity of sleep that a child gets is as important, if not more important, understanding the impact it has on insulin, the impact it has on grayling, the impact it has on types of food they choose, the level of activity they want to display, and motivation. So it often suggests that the frustrations that I encounter, and Claudia, you send me these kids and we focus on their obstructive sleep apnea, but understanding that if you can get a child to go to bed earlier and remove the technology from the room and encourage them to get a better night's sleep, you would see an impact as well. Enough so that the World Health Organization is coming close to saying this isn't an association. This is causal. And so every one of us knows kids that are overscheduled, overworked, and targeted at 11 o'clock at night, playing sports until midnight, getting up early to get some work done. We don't respect the quantity of sleep that these kids need. And it's a crisis. It just flies under it. Everything else that we do, we try to measure. This is a factor that needs to be addressed.
Yet another contributing factor. Great. Any more questions, comments?
Can you share in your program what you guys do specifically around treating, or if you treat like sort of stress reduction? And do you have any like group classes or kinds of
We don't do group classes. We just don't have the volume for a group class. We spend a lot of time, our psychologist spends a lot of time in not so much stress reduction per se, but in problem solving, which in turn reduces the stress. So a lot of time is spent on that, figuring out, going through problem solving techniques with written homework. Okay, pick a scenario and tell me about how it went next time.
I have a question for the audience. For those that didn't raise your hand about the case study, is somebody brave enough to say why? I mean, I think there are various reasons why you would not refer that specific patient to bariatric surgery, but a clear majority of the room did not raise their hand. And so can anybody speak to why you're brave enough to say why you would not refer? Would you wait until they hit 18 and then be more likely to refer? Is that a reason? I'm just curious because I find these data very interesting about how the general pediatric community views this. And I think the general pediatric community sees this disease through a very different lens than the specialists see it. And certainly as I see it from the research point of view. So I guess I'm legitimately curious to know why a patient like that wouldn't be referred. Somebody, anybody?
I'm guessing it's more the belief that lifestyle to take care of it, and it's still that sort of hanging on to that hope.
Yeah.
Surgery's so severe and it's so permanent. And also maybe some misconceptions about the risks of surgeries and thinking that the risk of surgery is higher and the risk of complication. So I bet there's an education component to why primary care docs. Because
I would ask along too. I mean, that you have a few years.
Right.
The result, you don't know what's going to happen. I mean, that it's not an end to the story. It's like to say, a procedure that most of the procedures can't take the big part of the stomach and it's non-reversible and you have the risk for death and complications.
Obviously, since it's a comment because I missed the initial part, so I don't know the whole case, but I have in my past practice been hesitant to refer, but the reasons are a little bit different. Some of it is adolescent tends to be a very quiet period.
Sure.
So not only does it, in my mind, increase the risk of the intervention ultimately failing, but it also increases the risk of the nutritional disorders.
Absolutely.
So that's a big part of it. But the other part of it, in my mind, is that we haven't really solved the problem because it's become very clear to me that it's, I've always heard it's all a matter of calories. It's become very clear to me that it isn't. So I don't, even though we're at least temporarily reducing what they can put in, there's all these other factors that we're not addressing. And so that, again,
But that's not true of all programs. Particularly if you are only an adult program, a teenager could come right in and sign right up without having any other intervention. Mm-hmm.
Could you comment on, I think you said 20% gain weight? That's one in 5.
Exactly.
So when you need to put somebody through, I'm not thinking so much of the risk of the procedure, but kind of how it will affect how they eat, and, socially, and then for the rest of their life, and 1 in 5, in the end, is just
It doesn't work.
started.
And in adults, there's been significant amount of effort in research in trying to identify what are the predictors. Who are those people before they have surgery? Can we identify those that are at particularly high risk after? One of those predictors of poor outcome is having a really high, sort of those super obese BMIs, those BMIs that are above 60s and the 70s. Those people generally have failed bariatric surgery, are more likely to have failed bariatric surgery. So degree of obesity is one of them. There have been numerous studies about baseline mental health status. Does that predict a better or a worse outcome? And the literature is just indecisive. It's not clear. Some predict just as equal outcomes with poor mental health as with good mental health. For a while, it was felt that binge eating disorder should be a exclusionary criteria, but now we know that in adults, at least, binge eating improves substantially after bariatric surgery. One small study in adolescents showed that that wasn't necessarily the case, though. So there's still so much more that we don't know. To me, this is a hammer only for those really sick kids. If you have a kid who's big and has type 2 diabetes and severe obstructive sleep apnea, yeah, it makes more sense. It's more cut and dry. The rest, it's hard. It's hard to make the right decision.